KETV Newswatch 7, chronicling the stories impacting our community. Stories making a difference. Stories that matter to you. This is KETV Newswatch 7's Chronicle.
We're really taking things day by day here. And I think that this is, as I said, sort of a brave new world.
It's really a moving target as far as trying to find what to give these individuals is the safest and the best, because there's no established treatment.
So if you practice hard, which I think we've done, when the real time comes, it's a defining moment.
And Nebraska Medicine's biocontainment unit, along with its doctors and nurses, not only rose to the challenge, they became industry leaders in treating Ebola patients. This fall, they were put to the test 3 times, successfully treating 2 patients, losing a third who was already critically ill when he arrived. Well, thanks for joining us. I'm Rob McCartney, and this is KETV Newswatch 7's Chronicle. For the first time, we're talking in depth with the doctors and nurses at Nebraska Medicine who are on the front lines in the battle against Ebola. Men and women who've set the standard for care, doing what it takes to save lives. Now, earlier this month, Time magazine honored those warriors, naming the world's Ebola fighters its Person of the Year, saying these men and women risk, persist, sacrificed, and save. As for the virus, though, the hot zone continues to be West Africa. All the countries highlighted here are actively fighting Ebola. According to the World Health Organization, there have been more than 18,000 cases in Guinea, Liberia, and Sierra Leone, most confirmed in the lab. So far, Ebola has claimed the lives of more than 6,800 people. Well, right now, U.S. hospitals and health agencies around the world are learning from and are starting to use Ebola best practices perfected right here in Omaha. In fact, in December, Nebraska Medicine held 2 seminars sharing what's worked for them with more than 100 medical professionals. And as KETV Newswatch 7's Alexander Stone reports, it's a commitment doctors and nurses take very seriously.
Standards that our staff has created have become the standards for the world.
The Med Center is making a mark globally as lessons learned in the biocontainment unit have become the new standard of care.
With our personal protective equipment guidelines and protocols, we've been able to share those really almost worldwide.
Practices used in the biocontainment unit recently helped set new CDC guidelines for safe treatment of Ebola. Shelley Schwedhelm says the new guidelines are almost up to Med Center standards.
With the exception of they're suggesting 2 pair of gloves, and we actually use 3.
And she credits this success to a staff that didn't give up.
Instead of a time where they could have become more fearful, they were very confident in what they were doing and chose to use that as an opportunity to educate others.
Educating others is exactly what the Med Center is doing now. Dr. Phil Smith says Wednesday the phone hasn't stopped ringing.
We have all had hundreds of requests and hundreds of phone calls and for various specific questions about advice. And
as the questions keep coming, the Med Center is looking for a way to share all its staff has learned.
We're looking at a number of options ranging from developing videotapes, developing curricula, having courses on site where teams of people could come in and tour our unit and see how we do things.
And now that the biocontainment unit is patient-free, Smith says the focus will be on figuring out how to make those things happen.
I think we're going to use that time to try to share our knowledge as best we can with the rest of the world.
That was Alexander Stone reporting. And joining me now to talk about what they've experienced over the past several months are Dr. Phil Smith. He's director of the Nebraska Biocontainment Unit, Assistant Director and UNMC Dr. Angela Hewitt, and also Nurse Shelley Schwedhelm, who is the Director of Emergency Department and of Trauma and Preparedness Services. And welcome. Thanks very much for joining us. First off, Dr. Smith, I want to ask you, why Nebraska? What was the genesis? I mean, we are certainly not the closest to the region where Ebola is the hot spot.
Well, I think following 9/11, there was a great deal of emphasis put on preparing for a bioterrorism event, which was our major concern then. And Nebraska, for reasons that are not entirely clear, decided with great foresight that we wanted something beyond the usual TB isolation room we could get in the hospital. We wanted something that could provide protection to our hospital employees. And remember, this occurred right after the SARS epidemic, when quite a few healthcare workers got sick and died in Canada. So we thought we'd build a more elaborate unit. At that time, we did not have many prototypes to learn from, so we went down to USAMRIID, the military unit at Fort Detrick, Maryland, and Emory unit, got some ideas, came back and built it over a year and opened in 2005. So we really had 9 years to practice, so no wonder we were in such good shape.
That was interesting. I mean, the foresight that you mentioned, you started out as a tuberculosis isolation, is that right?
No, I said we were trying to exceed that.
Right, that's
the
what
regulations said you need to be prepared for a contagious disease, and most states and most hospitals interpreted that as their routine isolation. And we thought we need to go beyond that if we encounter a disease like SARS or smallpox. Smallpox was our initial focus because that was thought to be the most likely bioterrorism agent we might encounter. But we knew when we practiced that the worst diseases you could potentially encounter would be smallpox and Ebola. And we were more thinking about smallpox, but we were also preparing for even something like Ebola. So we kind of got the ultimate challenge.
Well, Dr. Hulett, what was and is the hardest part of dealing with something this contagious?
I think just the newness of the whole thing, and the fact that this is a disease that really hasn't been dealt with in this type of facility other than ourselves and Emory before. And I think that our abilities to do things like check lab work on these patients, do some of the medical care that just wasn't available over in Africa, and all of this was just new. And I think that's something that in our medical careers we really haven't encountered before. And I'd say that was the biggest challenge, is just not really knowing what to expect.
And Shelley, how about for you, from your angle? What's been the most challenging?
I think it's all the logistics that went into making sure that everything was done just exactly right, because that's critically important, and I think it goes back to our team and how remarkable they are as individuals and how excellent our protocols were that we tested over those 9 years. But I think that those are the very things that can go wrong if you aren't very meticulous, and so I think that was probably one of the learnings as far as...
Well, let's talk logistics, and we've had 3 patients. Start with Dr. Richard Saker. He's the first one, arrived here September 5th, was here 20 days before being released. Who got the first call? I don't care, whoever wants to address that. Walk us through that process.
Well, we got the first call. First of all, when cases started to be repatriated back to the U.S., U.S. citizens, first who went to Emory, and then we knew it was a possibility that they would bring a case to us. But the State Department visited us in August and said, Emory's filling up, we need other places, and there are very few candidate hospitals. So they came and visited us, they liked what they saw, and then a month later we got the call and they said, we think you've got a very nice unit. In fact, we'd like to test you out with a case of Ebola. So Shelley did some amazing scrambling. We were basically ready, but maybe you mentioned the amount of preparation in the last 48 hours beforehand.
So what'd you do?
Well, there's a lot of just detail work that needed to be done. It's kind of, for 9 years you really run a unit on a very limited budget and try to be as efficient as you can without having all the supplies and meds and all that kind of stuff kept in the unit. So really what we did was just really get the staff engaged during that month between the State Department and getting the actual first call and having them kind of come in and just fine-tune things that we'd practiced and prepared for. And I think just those last 48 hours were just all the details of making sure that we got the unit stocked, that every thing that we needed to test was tested, that the unit was functioning exactly like it was designed, and all of those kind of logistical things.
Well, walk us through what the daily routine was like, Dr. Hulett. I mean, what was it like inside the unit during those first days?
Well, like I said, it was a new experience for us, for sure. This is not the usual sort of a routine that we normally would have going to see patients in the hospital. We would come in and put on our personal protective equipment to go in the unit, and we use varying types of equipment depending on where you're going to be. If you're going to be in the so-called hot zone in the unit with direct contact with the patient, or if you're going to be in the nurse's station doing other tasks. And so we would, put our equipment on and go in, and then we would actually, one physician would go back into the room while the other physicians and nurses actually sat out in the nurse's station, and we would essentially have rounds, which is sort of like what we did in the hospital, only in a very interesting environment, I guess. And so we were able to use our video system to actually interact with the patient and the physician in the room, and that way that would not only limit the number of people who actually went into the room exposure-wise, but then also we still were able to, like I said, do essentially rounds, which is something we're all familiar with. It was just in this sort of unusual circumstance. And so we provided direct care for the patient and ordered labs and did things like that, just in a different scenario than we usually. It
seems to me during those early days, during his whole stay, the community held its collective breath. I mean, we didn't know what to expect. Any kind of word coming out from your institution, we were like, what's going to happen? Is this good? Is this bad? When did you realize that Dr. Saker was going to make it, and what was the reaction? Were there high fives and fist bumps in the biocontainment unit, or what was it like?
Well, I think when he came in, he was critically ill, so we really had two problems. Number one, we had to treat a patient who was critically ill, and number two, we had to deal with this disease with a 50% mortality rate and try to follow all our protocols perfectly. And so the first couple of days it was touch and go, and then things started to improve, and I'd say by the end of a week we felt pretty confident. But when we talked to family and when we talked to the media, we were cautious because we know that there are some patients with Ebola that look like they're doing well and then they go downhill after a week or so. So I would say that we, after about 1 week, we started to feel fairly confident, and there were no high fives until he was on the way out the door.
That's right.
But that was quite an event for the staff, wasn't it, Shelley?
It was. It really was. I remember a moment prior to the day he came out of the unit, and that was a couple days before that when we first got his first negative test back. And I think as a leadership team, I think we were all kind of emotional when we got that first test back, just because we're thinking, my goodness, we really kind of did this, you know, along with our team. But I would agree with Dr. Smith that the day that he came out of the unit, Ebola-free, and we had our team there to greet him and his family there to greet him. It was just a really emotional day.
And I do want to say, you say negative test. Negative, actually, in the medical world, is a positive, is a good thing.
Yes.
So, just in case people misunderstand that. Okay, understand that. Second patient, Ashoka Mukpo, arrived here October 6th. He left on the 22nd. Was his treatment any different than Dr. Saker's?
It was actually very similar. He did arrive a couple days earlier in his clinical course than Dr. Saker did, so he was not quite as ill on arrival, but still fairly ill, but not quite as ill as Dr. Saker was. And so essentially, though, his treatment was very similar, with the exception of the experimental drugs, which we used a different one with Mr. Mukpo than we did with Dr. Saker.
Was there a comfort factor? I mean, my experience has been the more you do something, you tend to be more comfortable doing it. You've already had one patient under your belt, so to speak, and now you have a second one. Was there a comfort factor there?
I'm not sure I would say comfort. For sure, I guess we felt a little better about it, only because we had done it once before, and we knew a little bit about what to expect. We also were more familiar with our protocols in the unit, and the fact that now we'd had an activation, previous, and so we were able to, to really say that not only do we think we knew what we were doing, but we actually did it, and we did it well. And our staff, I think, is definitely we should commend them for that, because they did a great job evaluating those protocols on an ongoing basis.
Seemed to work out pretty well. Let's talk the third patient. Dr. Martin Celia arrived here November 15th. He died 2 days later. Now, I know medical professionals try to not take things personally. I mean, but you can't help it. I mean, you're human beings. You do get somewhat emotionally involved with the patients. It has to be frustrating, because he seemed like he was so much further along in the illness progression. Is that frustrating for you all? And tell me what you were thinking about that. 2 days.
Well, it was very frustrating. We had him 36 hours. And after the initial assessment, critical care medicine was very helpful to us throughout all of our patients. And infectious disease sat down and assessed what his chance of survival was, and it was about 10%. And so we knew it was an uphill battle, and things didn't go well. But in spite of that, every doctor and every nurse there put all they had into it and took the usual risk of dealing with a disease like this. So it's I guess if you don't feel bad when you lose a patient, you probably ought to find a different profession.
Absolutely understand that. Is this an area where more research needs to be done, as far as when you get somebody who's already that far along in the disease? Is that where the research needs to be done?
I think there's a lot of area of research actually that we need to focus on with this disease, but yes, I would say that describing the patients that actually progress to that level and what we can do to help them, as Dr. Smith said, I mean, he got essentially a full complement of critical care medicine that was delivered to him, and in spite of that, the outcome was not good. But I would say that looking at just the clinical course of this, along with the treatments, I think is incredibly important, so we'll know how to treat this disease in the future. Interesting.
We're going to talk treatment. Up next, some more on that treatment, and also separating fact from fiction when it comes to Ebola. Also going to discuss the downside of treating disease when there's so much misinformation out there. Plus, there are also scammers out there trying to make a quick buck by scaring you, promising protection when they're really just preying on your fears. That and more when KATV News Watch 7's Chronicle continues. Scammers are preying on scared Americans who are afraid of getting Ebola. It's become so bad, the Better Business Bureau issued a warning reminding people to be skeptical and not believe every claim you see. There are currently several unapproved and fraudulent products being pushed to treat Ebola. But remember, there are no FDA-approved vaccines or drugs on the market. And it goes beyond scams. PolitiFact, an independent fact-checking journalism website, called Ebola exaggerations the biggest lie of 2014.
People said that maybe you could get Ebola through sneezing. That was wrong. They said it was very easy to catch. That is not true either. A congressman suggested that illegal immigrants were bringing Ebola over the Mexico border. That's just flat out wrong.
And no one knows that better more than these three countries' leading experts on the disease. You're watching KETV News Watch 7's Chronicle, and joining me, Dr. Phil Smith, Dr. Angela Hewitt, and Nurse Shelley Sweethelm, all from Nebraska Medicine, and you all have been on the front lines of the battle on Ebola. And the PolitiFacts lie of the year, Ebola being used to push certain agendas. I know scientists, you don't want to get into that, you're focused on facts, but that's got to be frustrating when you have that misinformation out there.
Well, it is. I mean, I don't know. You have a disease that has affected over 17,000 people and killed about 50%, and it's contagious. And that, to me, is undeniable. I think we have to keep the fear in perspective. It doesn't spread like flu, like wildfire through populations, and I think we've done a good job of containing it in this country. So that, in that sense, we have to be careful not to exaggerate the effects of it. On the other hand, globally, it's a devastating infection. It obviously has an extremely high mortality rate.
Well, what are some of the misperceptions that people have about Ebola?
I think the common one is that people think it's airborne. Well, obviously it's not, and that's been proven over many, many decades and a lot of past history. That's probably one of the most common ones that you hear.
Another one is that it can spread before you're sick. So
Right.
if you encounter someone with Ebola and then walk around and you're not sick yourself, you're not going to spread it to anybody. So this is something that has come up even with our staff now and then. People think that they might be somehow carrying this and they're going to spread it to the population, which is completely wrong.
Well, someone actually asked me that just the other day. They said, okay, say for example, Dr. Sacra, he is now, he's Ebola-free, if you will. He can't get it again, but can he be a carrier somehow?
No, the CDC sets the criteria for release from the hospital, and you need to have 2 tests for the virus that are negative, or meaning showing no virus. Right. 2 tests in a row. In fact, we did 3 in a row in him a day apart, proving that the virus was gone. So he's no more danger than anyone else. He's out there wandering around, and the only danger he has is that people might recognize him and discriminate against him because of their fear.
And along those lines, actually, it's interesting you bring that up, because have you all been treated any differently since this all came out and you've become the public faces and on the front line? Have people come up to you and said, oh my gosh, you guys work in the biocontainment unit?
Yes.
Have they really?
Yeah. So you might want to mention some of the staff
I think,
stories.
We had some staff, especially early on, much less now, that perhaps had children who were invited to things that then were all of a sudden disinvited. Or even during the holidays, we had an individual who was disinvited. And I think it just goes back to the importance of education. But we talk about that as a team, and I mean, some of them are kind of like, can you believe this happened kind of thing, so it's becoming less and less. I think we're getting the message out.
I understand.
You've talked about the fact that most of the feedback you've seen is positive.
Yeah, I would say that probably 98% of the feedback that I've gotten has been positive, and people do stop me sometimes, even out in public places, and say thank you for what you're doing or things like that. And so I was concerned about those issues, about people perceiving us as, as either bringing Ebola to Nebraska or carrying the virus in some way or something like that. But in actuality, that's not really been our experience. It's mostly been positive, with a few notable exceptions.
I would agree.
You have kids, right?
I do.
How do you explain it to them?
I sat down with them actually before our first patient arrived, and I really told them, they know what I do for a living. I mean, they're young, but they understand that I'm a doctor and I treat infectious diseases. And I just said, we'll be receiving a patient soon, and he's a person that needs help, and I'm going to go help him. And that's really what I told them. And I told them if their friends question that's what they should say is, my mommy's a doctor and she takes care of sick people. And that's essentially what they've gotten. They haven't really received any feedback that's been, at school or anything else other than your mommy's on TV. I saw her on TV last night. That's basically been about it. So it's been good.
That is good. Yeah. Not necessarily being on TV part, but understanding, being up front with them is great. Right. Well, up next, what can we expect in the new year as we try to contain the Ebola outbreak? What's Nebraska Medicine's role going to be? First, a reminder, your comments are an important part of the show. If you want to be heard, a couple ways you can do it. Call us directly, 402-978-8960. Speak clearly, may use your comments on the air, or you can always email us going to KETV.com, click on the Chronicle link. What do you think about this topic? We'd love to hear from you, and we'll be right back. Watching a special KETV News Watch 7 Chronicle on Ebola in America. We've been talking with Nebraska Medicine doctors Phil Smith and Angela Hewlett, along with nurse Shelley Sweethelm, all of whom work in the biocontainment unit at Nebraska Medicine. And thanks again for being here. I want to start briefly here in the last few minutes we have talking about the treatment. I mean, no medicines, as I understand, have been, as we're speaking now, officially approved for dealing with Ebola. Several are being tested, among them ZMapp. Y'all use ZMapp, correct, in all three cases?
No, just one dose in one case.
Just the first case?
That was all, no, the third case.
Oh, okay.
And that's there was only one dose available in the world at that time.
So what's your takeaway from ZMapp's effectiveness then?
Well, we really can't. Every patient we had and every patient we know about at Emory and in Europe had a different treatment program. So it's very hard to draw conclusions. The numbers are small, treatments are difficult, and so just because one patient got better or didn't get better, you can't draw many conclusions. I know the CDC trying to put all this data together and make some sense of it, and ultimately the plan is to design a trial, an organized medical trial comparing some of the different medicines to see what works the best.
Now, reading online, another doctor in Sierra Leone has contracted Ebola, and in discussions on where he should go, one comment said, I would request Frankfurt in Germany or Nebraska, along with ZMapp and a hemopurifier ASAP, in order to have the best chance and highest probability to have an injury-free recovery. I mean, that speaks highly of Nebraska medicine, does it not?
Sure, sure.
And so what's your reaction when you hear that?
Well, I'm happy to hear that. I mean, I think that's been something that we've been very proud of, as we feel like that we're really on the forefront and trying to, to help with this fight. I would say the folks who are really on the forefront are the people in Africa. But we're here, and we're obviously, our bio unit's been around for a long time, as Dr. Smith mentioned, and we're ready to take care of people.
Do you expect to expand at all?
Well, the Chancellor has some plans, and he's discussed them with us, and we're trying to talk about the different options, everything from a separate building to a second unit to expanding this unit. I don't think we have room to expand this unit very much, and I think it needs to tie into a long-term plan that can deal not just with Ebola, but with Mideast respiratory virus and avian flu and whatever happens to come by, because as you know, it seems that every year there's a new disease, and I'm hoping that as a nation we'll be better prepared because of all the efforts that have gone into the Ebola planning.
And Shelley, I want to ask you then finally, what's the one thing you want people to take away from this when they hear Ebola, when they hear deadly contagious disease in Nebraska?
That we're prepared, and we've been prepared. And I think the thing that we're most proud of at this moment is not only that past success that we've had in caring for these patients, but our future in teaching and helping others become prepared. And so that's what we've been doing in the last few weeks, is really partnering with CDC and others across the country to stand them up and be prepared.
Well, y'all are doing great work there, and I appreciate you coming in and chatting about what's been going on. Surely a topic we're going to be talking about plenty in the new year as the global community continues to band together in hopes of containing the Ebola outbreak in Africa. Leading the way, our Ebola fighters at Nebraska Medicine. We're very proud of them. I'm Rob McCartney, and you've been watching KETV News Watch 7's Chronicle.